Hi, I'm Jared Gardner, and I'm here today with Dr. Andrew Rosenberg, a bone pathologist. Dr. Rosenberg did some very nice lectures on bone histology and embryology, as well as cartilage histology and embryology, and I'll put links to those in the video description and also in the upper right-hand corner, so you can be sure to watch those. Dr. Rosenberg was willing to also take a look at some unknown cases, so I pulled this case from my old teaching files, and this is a rare example of a whole slide, a large format whole mount slide of a bone resection. And you can see that this is the articular surface up here with the articular cartilage, and here filling up a large area of the medullary space is a light blue colored tumor. It's a cartilage tumor. And this was a low-grade cartilage tumor, and because of clinical reasons, it had to be removed en bloc. But the question that always comes up is, how do I tell apart an enchondroma from a low-grade or grade 1 chondrosarcoma? So I still, as a bone and soft tissue pathologist, I find that relatively challenging in some cases. So I wanted to have Dr. Rosenberg look at this case and give us his insights and his tips on how to distinguish these two entities, which can have areas that look relatively similar to one another in my eyes. So here's Dr. Rosenberg's comments on this case.
Okay, so what we're looking at here is a cartilage neoplasm. So cartilage neoplasm, certainly those that are intraosseous in location, grow architecturally as multiple nodules. And those multiple nodules, and you can see individual nodules here at low power that are sharply delineated by a rim of reactive bone that is being deposited, if you will, to try in some sense to confine its growth. And over a period of time, those nodules can coalesce, forming large masses of cartilaginous tissue. So at low power, we have a mass occupying lesion that is composed of hyaline cartilage. And assessing the biological potential of cartilage tumors, we rely on a variety of different histological features. One is its margin of growth. Are the nodules of cartilage well circumscribed, or are they growing with an infiltrative pattern? Infiltrative pattern is articulated by the tumor replacing the marrow space and completely surrounding preserved pre-existing bony trabeculae. So here we're looking at a nodule that's well circumscribed, and all the underlying bony trabeculae that were once there are gone. That means this tumor has grown slow enough so there is osteoclastic activity resorbing all the bone that was once there. Rapidly growing tumors grow so quickly, they grow faster than the osteoclasts have the ability to form and remove the bone.
Yes.
And so the bone persists while the tumor continues to grow. It replaces the marrow and then entombs the bony trabeculae. So here we have an area. Let's see if it really is.
One of the things I struggle with sometimes is deciding what's mineralized cartilage versus entrapped true background trabecular bone. I mean, do I look for the lamellar change to help identify what's a true?
So if you want to, I'm going to rephrase what you said to me, that you're trying to distinguish mineralized cartilage versus pre-existing bone.
Mm-hmm.
Okay. Many times they're different colors. Cartilage often is blue. It can be pink. So when it's pink, it can be problematic.
Yeah.
Pre-existing bone will always be lamellae. And so you should be able to identify, if this were lamellar bone, we should be able to see it.
That makes sense.
If this was bone, we should be seeing osteocytes. We should be seeing the osteocytic cell processes, because chondrocytes do not have cytoplasmic processes that extend out into the matrix. They live really in a smooth surface lacunar space whereas the lacunar space of an osteocyte have multiple holes to allow the osteocytic cell processes to extend out into bone. So when I look at this pink tissue with the differential, is this entrapped pre-existing lamellar bone, or is this some type of pink staining cartilage, or maybe something else? I can say it's not pre-existing bone, it doesn't have a lamella architecture, I do not see lacunar spaces, this is not pre-existing lamellar bone. And I have to find another reason to explain what this tissue is. So, going back to the big biological question here, is this a benign cartilage tumor or is it a malignant tumor? And I will address that. The one thing I want to show is this. We are looking at the cortex here. Remember from our first lecture, this is where our circumferential lamellae are. Here we have a nice example of our concentric lamellae of this Haversian system. Here we have this aggregate of lamellar bone, that is the interstitial lamellae. We are now moving into the area along the end osteal surface where we should have the inner layer of the circumferential lamellae. We can see that this eccentric nodule of hyaline cartilage is impinging upon the internal surface of the bony cortex. And what will happen over a period of time as this cartilage nodule increases, what will it do to the cortex? It will result in osteoclastic resorption of the cortex, producing a scalloping of the internal layer of the cortex, which you can get an idea is present here and is present here. And the radiologists use this internal scalloping on X-ray. They translate that into biological activity. And when they see prominent scalloping, to them that means, oh, the cartilage is growing. That means it's probably malignant. They will interpret the radiological images as indicative of chondrosarcoma. Personally, I think that is incorrect, because when you have an eccentric nodule of cartilage that grows, even though it's benign, biologically it's going to result in resorption of the bone. It has nothing to do with its capacity to metastasize. However, I will admit chondrosarcomas grow rapidly, achieve larger size than enchondromas. And as they get really big, they can result more and more bone resorption. So in low-grade chondrosarcomas, you will often see a greater degree of scalloping, but I never make a diagnosis of chondrosarcoma based on the presence of scalloping. The other features I use is infiltration, which up till now I have not seen, the degree of cellularity, and the degree of cytologic atypia manifest by the chondrocytes. So up until now, when I look at this large cartilage tumor, and it is large, it's going from the metaphysis into the diaphysis, I would argue, at least now with this superficial look, and I tend to be very conservative in my interpretation of cartilage tumors, that this is a big enchondroma. It's not growing with an infiltrative pattern. And benign tumors can get big.
Yeah, I've always found the low-grade chondrosarcoma versus enchondroma to be so challenging. I've had some mentors who told me you really don't make a diagnosis of enchondroma in long bones, and then
I would
say that's totally wrong, and you should.
That's not wrong. That's bullshit.
And I've had others who've expressed that, and said,
that's
no,
because they can't make they are. The way I view it is they have difficulty separating the two based on the way they're analyzing the cartilage.
So how do you deal with it when you have a curetted, fragmented biopsy, which is often what we see these days? I really struggle with that when it's low grade, how to handle that scenario.
Okay, I will answer that question. When there is infiltration, let's just say hypothetically this case shows infiltration, one would expect to see a small fragment of cartilage like we see here, in the center of which is a pre-existing bony trabeculum. So the bony trabeculum would be right here. It's a carotting. I only have a small piece, but I can see that it's infiltration. So I still believe when our orthopedic surgical colleagues curette this out, let's go to low power, and we see how the bone is rimming the periphery of the nodules, you will get a fragment of cartilage like this, and you'll see, hey, half of it is demarcated by a rim of bone. Mm-hmm. To me, that means there's a sharp margin. If I see bone trabeculum in the middle of that cartilage, that's when I get concerned or ask the question, is this infiltration or not? So how else do I assess the biological potential of the cartilage? The degree of cellularity. And very simplistically, when you look at cartilage and most of what you see is blue, that means most of the cross-sectional surface area is composed of matrix. That means it's hypocellular. If we are using as our reference, and I encourage you to use as your reference articular cartilage, it's hypocellular. Mm-hmm. That is the range that you would expect to see in Enchondroma, but there is a range of cellularity in Enchondroma. The other thing I pay a lot of attention to are the cytological features of the chondrocytes. And when I use the term cytological features, I am not referring to the size of the chondrocyte. I am referring strictly to the nucleus. A normal chondrocyte nucleus will look like a lymphocyte. So if we went back to articular cartilage, you look at a chondrocyte nucleus, it looks like a lymphocyte. Enchondroma, the nuclei are small, round, and dark, just as we see here. Low-grade chondrosarcomas, you have increased cellularity. The nuclei change. There may be about 1.5 times the size of a normal chondrocyte nucleus, and instead of being dark, they now have very fine chromatin. You can see small nucleoli. Mm-hmm. And that is, from my perspective, a manifestation of nuclear atypia. Is it enough to make a diagnosis of chondrosarcoma? Absolutely not. I want to see evidence of infiltration in cartilage tumors that are relatively hypocellular and are showing mild cytologic atypia. What's moderate cytologic atypia in cartilage tumors? You could imagine a nucleus 2 to 3 times the size of a normal chondrocyte nucleus. Instead of being nice and round or oval, will frequently have an irregular contour, becomes more elongate, and now reverts to being hyperchromatic. So it's an enlarged, irregular, hyperchromatic nucleus. When you see that type of nuclear change, that usually in a true chondrosarcoma will be accompanied by hypercellularity infiltration. Do I ever make a diagnosis of chondrosarcoma in the absence of infiltration? And the answer is yes. And all I can use is subjective terms. When there is moderate to severe cytologic atypia, moderate to high cellularity, where I feel it has crossed the line that no enchondroma with regards to whether it's arising in the digit, and I mention the digit because enchondromas in the digits are often hypercellular and show mild cytologic atypia. When I feel it's crossed that line with regards to the degrees of cytologic atypia and cellularity. And one other feature that I assess is the nature of the cartilage matrix. Most benign cartilage tumors are composed of hyaline cartilage. Many chondrosarcomas, the cartilage becomes myxoid. And what is the morphologic definition of myxoid cartilage? How do you distinguish myxoid cartilage from hyaline cartilage? By definition, hyaline cartilage, the chondrocytes are residing in lacunar spaces. You do not appreciate cytoplasmic processes. In myxoid cartilage, the chondrocytes are not in lacunar spaces. You then begin to appreciate elongate cytoplasmic processes, and it looks like a cell that has a stellate configuration floating in flocculent, bubbly basophilic matrix.
So these you would consider lacunar spaces?
Yes.
Okay.
So
So even though they're a little distorted, still...
They're a little distorted, and you can see this sort of amorphous, purple-like material within the cartilage. That represents mineralization of the cartilage. And if you notice, in this field, the area here, we see necrosis of chondrocytes. And it's in the area of mineralization. So the question is, what is the significance of chondrocyte necrosis in determining the biological potential of a cartilage neoplasm? In the setting of calcification, it's meaningless because normally, biologically, as we talked in the growth plate, when matrix mineralizes, chondrocytes die. If I see no mineralization and dead chondrocytes, yes, I will start asking myself, is this a chondrosarcoma or not? But in and of itself, necrotic chondrocytes are not diagnostic of chondrosarcoma.
And so for the curetted biopsy type material, and you don't see any obvious permeative growth or any of the obvious cytologic atypia, then do you just firmly say Enchondroma, or do you put some sort of a hedge on there of well, it may not be representative, as a relatively new pathologist in practice still, I mean, I've been practicing almost 6 years, but I still worry a lot about, am I getting the right diagnosis on a limited sample?
I think it's very healthy to worry about whether you're making the correct diagnosis on a limited sample. I could tell you my practice. I review the imaging studies, and I've come to feel very comfortable with my interpretation of the X-rays, which are an important correlate to the histology. So I have been trained by very tough orthopedic oncologists. They recognize two colors, black and white. They do not recognize gray. I do not hedge, except in extraordinarily infrequent situations. I say this is an Enchondroma. I say this is a grade 1 or grade 2 chondrosarcoma.
Okay.
If there are atypical features, I will use the term atypical Enchondroma and then describe what are the atypical features. And the atypical features are usually tumors that show increased cellularity, some mild cytologic atypia. But I've looked at the X-rays. I feel comfortable. It's not exhibiting or radiological features, which I think are diagnostic of chondrosarcoma, which would be, for instance, destruction of the cortex and the presence of a soft tissue mass. What do I do when I have those radiological imaging findings and I have cartilage that looks benign? I will describe it and indicate that it either represents, and it depends on where the radiologists have put their needle, it either represents an enchondroma that on imaging studies looks like is associated with a chondrosarcoma, or is a manifestation of a very low grade component of a low grade chondrosarcoma.
Okay.
So
that's really helpful. That's
what I do. But the WHO has created the category of atypical cartilaginous tumor to make it easier for pathologists who are reluctant or find it difficult to distinguish enchondroma from low-grade chondrosarcoma to provide some diagnostic terminology that the orthopedic surgeons can act upon.
Okay, that makes sense.
I don't use that term.
Okay.
And when that term was being created, I'm old school. I'm still benign malignant. I try to stick to that as best I can.
Well, I think it helps to learn from people who have looked at all of the different ends of the spectrum for a long time, and I think it's really useful to see different schools of thought and different approaches to things. I always learn a lot from each of my different mentors along the way. I've learned a lot from seeing the different ways they handle difficulties, and I'm still trying to figure them out as I go along too.
It is a lifelong process.
Now here is another large format section, a whole mount section of that same cartilage tumor that we've been looking at and discussing. Okay, and this is a really cool example of a safranin O stain, and it's a kind of an old school histology stain which is not used very often anymore, but you can see it's very beautiful. It stains the cartilage very nicely, bright red, and the bone this kind of aqua blue, bluish green color. So, and by the way, this slide here, I've scanned the slide, scanned the glass on a scanner so you can see the whole thing, but the actual size of the glass slide is about 10 centimeters long by 8 centimeters wide. Compare that to a regular glass slide that pathologists normally look at for routine specimens, and those are about 7.5 by 2.5 centimeters. So this is a really large slide, and I'm always impressed with the amazing skill histotechnologists have to cut any slides. I can't imagine the skill it takes to cut a large whole mount slide like this, particularly on a bone specimen. So I thought it was a real treat to be able to share these very cool and rare specimens with you. So here's Dr. Rosenberg's comments on this safranin O stained whole mount slide.
So what this, let me go to the articular. Yeah, so what this is a safranin O. So when we look at the tumor, it stains beautifully with the safranin O. Wow. And it highlights the distinction between the cartilage and the bone. And the bone is often this aqua blue-green in color.
Very beautiful.
So this would be, a way also to highlight infiltration. You can see some little bony trabeculae that are in there.
I think those are, because they have lacuna and stuff, right?
Yeah, I think this is bone, but it's at the very periphery of the tumor, and when you think about three-dimensionally, those cartilage nodules surrounded by bone, when you have a nodule of cartilage, a layer of bone that is surrounding it, and on the other side, portion of a nodule of cartilage, and you cut it like this, it looks like there's bone being surrounded by cartilage,
but it's just,
and it's an infiltrated pattern.
I mean, trapped around the fold.
That's right.
Of the
It's
tumor.
a plane of section. We're not seeing it in three-dimensionally. So what do I do in a curettage specimen where I see maybe one single focus of what looks like infiltration? Or I'll take a step back. I want to see sort of a significant amount of infiltration because I don't want to overcall a tumor a chondrosarcoma by virtue of a problem created by plane of section. So I like to see more than just one focus where bone is completely surrounded by cartilage. And if it's a curettage or an open biopsy or something like that, my expectation is I'm going to see it in scattered multiple places. And if I just see it in one place, I do not say, oh, this is diagnostic of chondrosarcoma.
Now, in contrast to the previous low-grade case, I want to show an example of a really obvious chondrosarcoma. So here's another case, and this is a regular-sized slide, not a whole mount slide. Unfortunately, I don't have very many of those. But this is an example, I think, of a very straightforward, obvious chondrosarcoma. And so you can hear what Dr. Rosenberg has to say about this case now.
So this is a beautiful example of infiltration.
Yes.
So we have pre-existing bony trabeculae completely surrounded by the cartilage.
And we can see the lamellar lines, right? So we know it's definitely bone.
Yep, it's bone and it's pre-existing bone. Mm-hmm. So what you want to see is pre-existing bone, not reactive bone that is being encompassed by the neoplasm. And we can see the other things that go along with chondrosarcoma. Increased cellularity. We talked about cytologic atypia in the form of fine chromatin, small nucleoli. I would say that based on the degree of cellularity and atypia, I'd probably call this a grade 2 chondrosarcoma. Grade 2, conventional, predominantly hyaline with some areas that look like it's also myxoid.
And what criteria do you use for grade 3?
So for grade 3, like imagine, not necessarily spindle, but imagine any high-grade sarcoma. dense cellularity, severe cytologic atypia, mitotic activity. Generally, grade 1, grade 2 chondrosarcomas, grade 1 almost has you generally do not see a mitosis. Grade 2, you're lucky if you see a mitosis. Grade 3, mitotic activity is easily found.
And so is this example of what you're talking about, larger open chromatin, much bigger than the little
Yes.
nuclei that look like lymphocytes?
Exactly. So we'll go to some cells that show that, like right here. This nucleus is not hyperchromatic. You can see the chromocenters that are present. You can see the nucleolus in this cell. This nucleus is more hyperchromatic, but notice it's big. It's much bigger than the nuclei of a normal chondrocyte. So it doesn't have an irregular contour, but it's big and dark, and that's what I expect to see in a grade 2 chondrosarcoma.
One thing I've noticed over time is that sometimes in reactive cartilage, like at fracture sites, the chondrocytes get quite large and have pale open chromatin, and I've always found that to be a challenging difficulty.
Yes, so if you just take the chondrocyte out of cellular callus and just look at that, there is morphologic identity with the nuclei of the cartilage. Excuse me. And it can be very difficult. So I look at other things. I look at the configuration of the cartilage. In the cartilage we saw, say, in the fracture callus, it is linear. Neoplastic cartilage is globular or round.
So here's where the clinical and radiographic and overall context come in.
And low power, looking at configuration of the cartilage. Also, fracture callus cartilage undergoes enchondral ossification. Here, we're not seeing any enchondral ossification. Right. So those would be some features I would say, no way is this fracture callus. This has to be chondrosarcoma.
And then, can I ask, that pink stuff right in the middle there, so that is collagenized cartilage or pink
I don't want
cartilage?
to say that. I would say it's pink cartilage. I can't tell you.
But it's not bone, right?
It's not bone.
Because that's what I've always struggled with, the pink dense areas. I don't know how to explain them. They look kind of like cartilage, but they're pink.
So remember what hematoxylin and eosin is doing. They're acid and bases, and they're binding materials based on whether it's an acid or base.
Sure.
So if the glycosaminoglycans, if their composition is different, so their acid base is a little different than normal cartilage, it may be staining with more eosin.
All that
so
biochemistry comes in handy.
Yeah, basic binding the acid.
That makes perfect sense.
So I agree it can be confusing, but get over it. Don't let it be. Just remember, cartilage can be pink. Look at the lacunae. Are there canaliculi?
Those are incredibly helpful tips. Really, really great stuff, and I think that this has helped me a lot of questions I've had many times. So thank you so much for going over these cases with us. And again, I think everyone else who's watching this at home will enjoy it too.
Okay. Thank you very much.